to present this case. Before that, I want to welcome all of you. Thank you for this opportunity. So, can we have the slides? So, I am a pediatric surgeon, but without the neonatologist and pediatrician support, I can't do any major cases. Okay, so to begin with, it's a team approach. And coming to the case, so this baby was delivered elsewhere at 28 weeks with extreme preterm and birth weight of only 760 grams. This is not very unusual, but for this kind of babies, specialized care is required. They cannot be managed at home or at normal hospitals. There needs to be a level 3 NICU care, for which this baby was transferred to our center, Apollo Cradle. During the course, on day 3 of life, the baby developed abdominal distension, that means swelling of the abdomen. So we did necessary investigations like X-ray of the abdomen, which showed free air inside the abdomen. That means we suspected some hole in the intestine of the baby. Since the baby was very much stable, we placed a tube to let out the air. But you can see on the X-ray the abdominal distension in the clinical picture. The tummy is looking very shiny, and the X-ray is totally black, free air inside the abdomen. So we placed a tube to let out the air so that the baby can breathe better. But after placing the tube also, the baby's breathing pattern was not improving. So we had to explain the parents about the possibility of going for a surgical intervention which may improve the baby's condition. So with all the pros and cons of the surgery, the baby was taken for surgery under general anesthesia. At this moment, I will take some time to tell the role of the anesthesia team, because without them, this case would have been very challenging to manage. So they did an extremely good job by stabilizing the baby. Then we did the surgery. So intraoperatively, that means during the surgery, we found a very large perforation or hole in the stomach of the baby. That was very unusual, because for such a small tiny baby, and this large perforation was not very common to report. So what we did, we just repaired the hole and closed the abdomen after placing a feeding tube directly into the small intestine, just to give support to the baby for the feeding purpose. Otherwise, these kind of babies, they would have required long-term saline and protein and fat to be given in the peripheral lines, which has its own complications. So this baby did very well after the surgery. We initially started on IV fluids, then given lipids and amino acids through the vein. Then after 2 days, as the baby was stable, we initiated the jejunostomy feeds. Then slowly we changed to the oral feeding. Once we were satisfied that baby is accepting oral feeds without any complications, then we removed the jejunostomy feed, jejunostomy tube also. So the baby was discharged after 2 months of NICU care with a very healthy condition, and right now the baby is gaining weight and doing well. So here I want to highlight the team approach, the technique what we follow in the surgery, and the care we take during the surgery, because the surgery is not just surgery, it is the before surgery and after surgery how we take care of in this kind of very tiny babies. So this is one sort of that case we just wanted to report, but there are a lot of more cases which we do, like tracheoesophageal fistula and biliary atresia, then malrotations. There are a number of cases which we deal with, but this is an index case just for the public awareness that we are doing this kind of high-end surgeries, and we are capable of taking care of these kind of babies. Thank you.